You guys, looks like it's almost 7:01 here. I think we're going to get started. I want to thank Aaron Conger, Zach McCormick, Andrew Joyce, and Nick Kazmers for being here today to give us a grand rounds, which is something I've been interested in for a while, and I think a lot of us have many things to learn about, which is denervation procedures in orthopedics. And most of us will think about this in terms of radiofrequency ablation for different spine applications, but we've started to see this come in to play with the upper extremity. In our Journal of Hand Surgery, there are several articles now on denervation procedures for pain involving arthritis, and I think that this has the potential to bleed into other surgical subspecialties in orthopedics and elsewhere. And so I thought it'd be a good time to, first of all, get a little face time for Aaron, Zach, and Andrew for the department, and then also to kind of see how this might transition into our more orthopedic surgical world. So with that, I'll let you guys take it away.
All right, I'm just going to go share my screen. Perfect. Can everyone see that?
Great.
All right, perfect. Well, welcome everyone. Thank you again so much for having us. I'm Andrew Joyce, and I'm one of the newer faculty here at the Division of PM&R. And I'm going to be starting off just by talking about kind of the introduction, kind of going through the history, and then going over some technical aspects of joint denervation as we kind of frame the discussion that my colleagues will go into more specifics for. I have no relevant financial disclosures. And really what I want to do is go back kind of through the history and how did we get to where we're at now, and then really take some time to kind of go a little bit over the technical considerations, especially in radiofrequency ablation, where a lot of things affect the ability to properly do denervation. And then hopefully pose some questions that you guys can think about as you go through the other sections to hopefully stimulate some discussion. And so kind of at the base level, we all know this, joint denervation is surgical transection of the afferent joint pain fibers, which transmit pain from the joints into the brain. And really kind of the main figure when we go back is someone called Nicholas Rudinger. And so this guy has a really interesting history, actually. He first actually started off as a barber. He did a barber apprenticeship from age 14 to 18. And this was back in the history when, barbers, surgeons, and dentists were all kind of thrown together in kind of a grouping. And so, I like to think that those clippers are actually trauma shears. And so after he finished that, he ended up getting a bit of an inheritance. So he actually had some money. And so he then decided to take that time and do some medical training. And so he did that for another 4 years, at which point his plan was to become a war surgeon. And he was kind of all gung-ho on that. But one of his mentors, Theodore Bischoff, realized during kind of his medical training that Rudinger was just an absolutely fantastic anatomist. And so he convinced him to scrap that plan and instead advised him to go and follow him to continue doing anatomic dissections. And that's really where Rudinger made his name. And ultimately led to the culmination of his thesis, which was published in 1857, called Articular Nerves in the Human Body. And this is actually one of his dissections from way back when. And so you can see how detailed he was and was able to kind of describe the anatomy. And what was groundbreaking about this in terms of joints is that it, for the first time, proved that, hey, there are nerves that go to these joints that likely provide sensation. And so now that we knew we had nerves, there's something to denervate. And so that's where this got started. About 5 years later, John Hilton created this axiom that it's kind of wordy and kind of hard to kind of conceptualize from the way he kind of wrote it. But basically the idea is that nerves that control the joint, basically control the muscles around the joint, also provide innervation to the joint, and also provide innervation to the skin around the joint. And so that was kind of, again, confirming that, hey, there are nerves going to these articular joints. And then not a whole lot happened in the whole field of denervation. There's kind of this big gap of about 80 years before we start seeing some real changes from those initial anatomic dissections. And really, this is around the 1930s and 1940s is when things start getting taken off. And so Tavernier in 1942 then showed that you could have improved pain reduction after hip denervation. And then Nikias, about 10 years later, then did a publication on ankle denervation, and he used nerve test blocks to see if that would help with the pain. And then Wilhelm really took it to the next level and started doing joint denervation for hand surgery. And then Dellon, who actually wrote the book where this is coming from, did a lot of clinical and anatomic studies for joint denervation throughout. And so that's kind of what has progressed, a lot of this. Now I'd like to take a moment to kind of speak about radiofrequency ablation. And this is, what we frequently in the interventional pain world use to perform our denervations, particularly of the spine. But I figured it'd be good to kind of go through the history of that because it kind of has some parallels. So back in 1863, so this is about 5 years after Rudinger did his initial kind of anatomic dissections and published his thesis, he used direct current to cauterize the animal brain. And so he showed that, you can use electricity to basically cause lesions and kind of focal lesions in certain areas. And then again, kind of nothing happens for a really long time. And finally, kind of where this starts taking off is in 1928. And this was something I didn't realize, but basically the Bovie knife that is commonly used in surgery is basically its own version of kind of a monopolar RF technology where you use it and you just have it set up to cauterize tissue. And around when this was created, Kirschner was the first one to actually use kind of ablation and thermocoagulation to treat pain as a condition. And so he treated trigeminal neuralgia by thermocoagulating the trigeminal nucleus. Took another 20 or so years, and then we started having our first commercial RF machine. But it wasn't until 1975 that finally it was first done on the lumbar spine. And this is where I think things took off and it became more commonly performed. In the 1980s, the technology advanced, and then the use in pain medicine finally started becoming established, and we started having more and more studies by the early 2000s showing that this was, indeed safe and effective treatments. And then throughout the 2000s, kind of maybe the 2010s, is where we started having newer technologies that started coming up. And I'll touch a little bit on these in the future because they have kind of technical considerations. But we started developing cooled radiofrequency ablation and pulsed radiofrequency ablation and kind of changing the probe size and orientation and things like that, all of which can be helpful for making radiofrequency ablation more effective. And so kind of when we're thinking about this, it's, well, why do we use RF? And these are kind of questions that I've gotten from some of my residents or med students throughout the time. Why not other forms of neurolysis? So I know when we do our pediatric rotation, we'll use phenol sometimes to kind of do ablation and do it in other ways for other nerves that we targeted. But what's nice about RF is it's very precise. We can really target the structure we're looking at and really avoid any structures that we don't want, which is important in the spine where, your spinal nerve is maybe, half a centimeter, distal to the tip of a radiofrequency probe with, if you're using traditional thermal radiofrequency ablation. And so it's great in that way. Now, I'm not a physicist, so bear with me as I try to go through this part. But basically, I'd like to give kind of just some background of how radiofrequency works. And so when we look at the electromagnetic spectrum, there's kind of these waveforms, and they range from kind of very low, which is 10 hertz, which means 10 beats per second, all the way to 10 to the 28th, hertz. So really broad spectrum there. And what humans hear is kind of down in this lower region, in the extremely low and very low frequency, where we kind of hear from 20 hertz to 20 kilohertz. But as you go up, in terms of hertz, you kind of get to radio waves, and then if you keep going faster, you start getting visual light, and that's how we perceive that, and all the way up to X-rays. And so radio waves are really what RF, that's what the R stands for, uses. And so what happens is we have this high frequency current that's stimulated in the tip of the electrode, and that current gets sent to the grounding pad. And basically the electromagnetic field around the needle tip heats up and then causes a lesion into the tissue. And importantly, for traditional thermal radiofrequency ablation, there's a couple things that really affect kind of how big your lesion is. So the electrode size, so if you use a bigger electrode, you get a bigger ablation. The electrode orientation, and this matters a lot for us if we do traditional RF and the spine. We have to orient our nerve parallel to the nerve that we are targeting because it helps ablate it more. The temperature generated matters, and you can't be too low, otherwise you don't really have any damage, and your temperature can't be too high, otherwise you just kind of thermocoagulate everything, and basically you get char on the outside of your radiofrequency probe and not a true kind of lesion. And then finally, the local tissue fluid content matters. And so sometimes we alter this by actually injecting what's fortunate is, injecting lidocaine for pre-procedural pain is great, but it also helps increase the size of our lesion and can help, make it more likely that we will have the lesion size that we desire. And so this kind of illustrates some of the differences in those technologies that I talk about. So if you look at B over here, that is kind of the traditional thermal radiofrequency ablation. So you have an insulated needle, and then the tip is the part that runs the radiofrequency current through it. And what you get is kind of this ovoid lesion there. Now, newer technology, which on the left you can see an A, and to the left of that is cooled radiofrequency ablation, which is, I think, what most of us providers are using here at the University of Utah. And what's advantageous about this is basically while the lesion is being created, cool water is running through to prevent the needle tip from getting too hot and preventing the tissue from charring over. And so this has kind of two distinct advantages, and one that it makes the lesion size much bigger, that you can see from the picture. But also you create kind of a spherical lesion that extends past the tip. And so you can approach ablation with kind of much more ease. You don't have to be as specific in how you target it to make sure your lesion is perfectly parallel with the nerve. And that makes things technically just a lot less challenging for us. On the right here, you can see kind of another version, which is the trident. And basically what happens here is after you place the needle, you can deploy the three prongs that go and heat up and create the radio frequency. And this also kind of creates sort of like a pyramid of tissue destruction. And so this is another way of kind of increasing the lesion size, making it more likely that we target the nerve that we want to, without having to be, perfectly exactly parallel to it. And this is just one of those other questions that I get a lot of the time is, why is this not permanent? And so, when radiofrequency ablation does cause damage, and there was some thought historically actually that it specifically affected the, the pain fibers, like the alpha, delta, and C fibers of the nerves, although that hasn't fully panned out when they've looked at histology. But what they did find is that radiofrequency typically does not completely destroy the basal lamina of the nerve. And so this provides kind of scaffolding so that the nerve can, in fact, grow back. And that's why we see after we do a radiofrequency ablation of the spine or of the knee that frequently, within 6 months to 2 years, somewhere in that range, people start having return of their pain because those nerves come back. And then another question I get frequently is, what are the long-term effects of this joint denervation? Are we going to be causing more harm? Or a lot of patients are worried, well, if I can't feel it, am I just, doing more and more damage? And it's a reasonable concern. One of the things that I found kind of interesting as I was going through some of this literature is that, I always wondered, well, why don't we get a Charcot joint in the spine? Why doesn't it just totally deteriorate? And what I found is that actually a lot of the proprioception that we have in most of our joints is based on cutaneous tissue, actually. So when you go and you denervate the area, people can still, within 5 degrees know where their hip is in space and know where their knee is in space just based on their cutaneous tissue. So if you don't have kind of cutaneous loss in addition to the total denervation of the joint, you're not going to develop kind of that increased destruction of the joint. And so you actually need a lot of things to kind of line up to create this Charcot joint and lead to damage. With regards to instability, that's something that Dr. Lawrence and I are actually looking into and just kind of collecting data on. But we're looking to see, do these procedures, lead to instability in the spine in people who are already kind of at risk for that. And so it's still being worked out. But based on kind of these requirements for the Charcot joint, I'm optimistic that it won't be a significant side effect. And so with that, I'd kind of just like to pose the following questions as we go through the remainder of my colleagues' talk. So, should joint denervation should have a greater or should it maybe have a lesser role in the management of intra-articular pain? Are there financial implications that we really need to consider on how this, using denervation instead of some of the other treatments that we have? Should that affect physicians and affect patients, and what are the implications of that? As we continue to get more and more technology and our technology and techniques get refined, how will this kind of affect the future management of patients? And should we really be prepared for a major shift in the management of articular pain with denervation taking a greater role? And with that, I'll leave it on for the rest of my colleagues.
So are you going to allow questions between these talks, or are you going to allow them after?
I thought we'd wait till afterwards, Dr. Saltzman, but if there's anything that seems especially relevant, I think it's fine to interject.
Okay.
Good morning, everyone. Zach McCormick. As I'm getting these slides up, I'll reinforce our appreciation for being invited to be a part of this grand rounds. One sec. We're I think sort of goes without saying, but obviously between PM&R and orthopedics, we have a great partnership, and we only want to reinforce that. So, frankly, denervation for multiple pain indications is a big part of our, our clinical practice, at least who you're hearing from right now, among other things, but also a big research interest. So, Dr. Joyce just framed this really nicely. I'm going to specifically talk about denervation for spinal pain. And this is an area, I'll also just mention, I do and we have research grants from Avanos and Relievant. These are companies that do produce radiofrequency ablation technology. So I'm going to keep this brand agnostic, of course. I'll just point out, when I'm talking about a study that involved research funding that we received from industry. I'll point that out. But denervation for spinal pain. So as Dr. Joyce alluded to, this is old stuff, right? So we have sham-controlled randomized trials, back to the early and mid 1990s, establishing, in particular in the cervical spine, the efficacy and effectiveness of radiofrequency ablation for chronic spinal pain indications in facets in particular. So I will talk about vertebral end plate pain. This is sort of being more of an emerging area. But as you saw, lumbar facet pain, also cervical, this is really well established. There's not much debate. I'll talk about some of the things that we're doing to advance this area and optimize these treatments. But we know that it works in the properly selected patient. In the interest of time, I'm not going to talk much about the sacroiliac joint, but this is also an area that is relatively established. It hasn't been done for quite as long as spinal facet denervation, but there are two separate independent sham-controlled randomized trials that established this as an effective treatment, and a whole body of literature, again, saying that if you denervate the lateral branch nerves along with the L5 dorsal ramus, that it's an effective treatment for, again, properly selected patients. So I'll show you a little bit of our own data. This is actually, Dr. Conger really was the primary driver on this one, but this is our own audit. So this is an audit of our own clinical practice data from the past several years. So if we select patients according to best practices, which is diagnostic medial branch nerve blocks, this again is for lumbar spine specifically. We primarily use cooled technology, as Dr. Joyce alluded to. And if we use the bar of 50% as considered success at 6 months, these are the numbers that we see in our own practice. So about 56, 57% of patients are reporting a minimum of a 50% relief after 6 months after their ablation. If we sort of do that sensitivity analysis and increase the bar for what we consider success, it starts to, of course, decrease, but we see about 13% of patients have complete relief of pain that's durable to at least 6 months, and we have longer term outcome data as well. But this is, in the world of chronic axial spine pain, this is pretty good, right? There aren't that many treatments where we see outcomes that are this good within sort of this niche of patients. So, where have we gone? Again, there isn't really debate that this works, but the question is how can we better select patients? How can we, optimize the treatment paradigm itself? Dr. Joyce actually sort of framed the technology nicely already. So on the left side here, you're seeing what a cooled radiofrequency ablation lesion might look like. This is a conventional, really the original older technology, ablation with more of an ovoid lesion, like Dr. Joyce mentioned. And so, is there a difference if we compare these head to head? And this is a bit of old work when I was actually a civil trainee at Northwestern, but we did a trial comparing the two. We selected based on a single diagnostic medial branch block, and we did see a trend towards a greater responder rate in the cooled group compared to traditional. You can tell we were underpowered. This was done with a $3,000 foundation grant. So we are planning actually to do a properly powered study with probably about 150 patients comparing these two technologies. And then Dr. Burnham, who is currently a fellow with us and joining our faculty as soon as he's done in July, and will be establishing a practice up in Farmington. He is actually working on a grant proposal to look at a different technology. This is that Trident technology that Dr. Joyce mentioned, comparing that to standard RFA and looking for any potential treatment benefit or any differences essentially between the two technologies. We suspect that time will be significant. Procedural time it'll be faster. Not sure whether the outcomes will be much different. And then we've also looked at RFA versus other standard of care. So not sort of a technology comparison, but other treatments we use commonly for facet joint mediated pain. And I think many are familiar that steroid injections, incredibly common treatment for joint pain. We certainly use them for facet joints, and it is considered a standard of care. So we currently are enrolling for, this is a randomized trial of medial branch ablation with cooled technology versus intra-articular facet joint injection. We're up to about 97 patients. We need another 20 or so. Results pending there. But believe it or not, as long as facet steroid injections have been performed, which is many decades, and similar with radiofrequency ablation, no one's ever done a proper comparison when patients are selected appropriately with dual medial branch nerve block. So if you inject everyone with low back pain, many of them do not have facet pain, so you're going to sort of wash out the treatment effect of either treatment. And then Dr. Joyce actually mentioned the study, so I won't go into detail with it, but he and Dr. Lawrence, I should have included a picture of Dr. Lawrence as well, but are taking a look at whether radiofrequency ablation of medial branch nerves does potentially destabilize the spine, whether it be in the context of spondylolisthesis or scoliosis. Our clinical experience says no, it doesn't likely, but that's not data driven, and this comes up all the time. So, we're mining the EDW and so forth to see if we can, put some actual evidence to this question. And then moving on to vertebrogenic pain. So this is really an emerging area. And so I think, many are excited about this as a phenomenon that is gaining traction as far as a potential etiology of a subset of chronic axial spine pain. And really what we're looking at here, and I don't have time to go deep into the basic science, but at the end of the day, there are a couple decades now of basic science that support the idea that modic changes, and here on the right, you're seeing a type 1 modic change. So would be T2 imaging. You're seeing bright signal change around the end plate here, inferior end plate of L4 in this case, with an end plate defect that it's associated with, and then you're seeing kind of a dark change on T2 weighted imaging. So this is indicative of inflammation, edema, fluid, and then also type 2 modic changes, which is a proxy for fatty infiltration into the bone marrow. So it would look similar, except that brighter or relatively bright signal on T2 and on T1 for a type 2 modic change. There's also a type 3 modic change, which is really just sclerotic tissue, dark on T1 and T2. That does not correlate with back pain, and also doesn't correlate with a lot of pathologic markers that have been studied in histologic studies. So we see increased pain, nerve fiber density, vascularity, and they stain positive for various pain-related neurotransmitters in patients with chronic axial pain in the context of these imaging findings, as opposed to those who don't have those findings. So again, to make a long story short, there's growing evidence that these imaging findings do correlate with an anatomic source of pain. And this is a sliver of patients. Obviously, there will be patients with motor changes that are totally asymptomatic, but there is a fair correlation with chronic axial back pain. So then more recently, a technology was developed to target the basivertebral nerve. So this is a schematic here in the lower left, and this is obviously sort of a anterior oblique view, I suppose. But the basivertebral nerve really enters posteriorly through the vertebral body. It comes from branches of the sinovertebral nerve, and then it arborizes close to the midpoint of the vertebral body and sprouts out towards the end plates, both superior and inferior. And so given that this is the case, and this contributes the vast majority of innervation to the end plates, there was interest in, well, can we target this nerve the same way we can target a medial branch nerve, for example, for facet pain? And then this began to be studied. So what you're seeing here, this is what the technology looks like. So we access the pedicle, we insert an introducer, and then make room for a bipolar radiofrequency electrode, and that's what you're seeing here. This is at the this is sort of a transitional segment actually, but we'll call it the S1. Or a sort of a lumbarized S1 perhaps. And this is a lateral view of what that electrode looks like. So there was, of course, a pivotal study, a randomized sham control trial that showed statistically significant benefit to basivertebral nerve ablation versus sham. And then a follow-up study to this was BVN ablation versus conventional medical management. So really anything under the sun that wasn't spinal fusion. What I think caught my attention and many others was that this study was actually ended early by an independent data safety monitoring board because the RFA group was out competing the conventional medical management group by such a margin that the safety monitoring board said it was not ethical to continue to randomize patients, and that all of essentially the active control group needed to be offered crossover to RFA. And then we have even more recently, we have 5-year outcome data, and this comes from the original sham control trial of patients who underwent ultimately received crossover, I believe at either 3 months or a year, I'm forgetting, but this is the entire cohort that either was originally randomized to RFA or crossed over to RFA, followed out to a minimum of 5 years. Some of these represent patients who'd had a treatment 7 or even 8 years prior. And this is the data that is in that paper. So I think the things I highlighted here that really jump out are the opioid reduction that was durable out to 5 years. So many patients had reduced opioid use. As someone who spends a lot of time doing spinal injections, I think it's fairly impressive that they reported in this cohort that 93% had reduced or stopped receiving spinal injections out at 5 years after the index treatment or crossover treatment with RFA, the basivertebral nerve. And then finally, very few of these patients went on to receive spinal fusion. So what's happening right now, we are wrapping up a pilot study for a larger registry where we're looking at a kind of a restricted group of outcomes, pain, function, and opioid use. But this is the data I'm actually presenting to the Technology Assessment Committee tomorrow. So this is sort of hot off the press. I just pulled it yesterday. But this is our first 10 patients. We're going to go out to 20, but first 10 patients for whom we have at least 3-month outcome data. And if you consider 50% improvement in pain and a 30% improvement in the OSPO-S3 disability index, which these are fairly accepted bars for robust improvement in considering chronic axial low back pain, tough population. And if we consider this first treatment, this was actually one of my partners was not able to access the S1 pedicle. So, do you count this as a treatment failure, or do you count it? Well, if we use intention to treat, we do count it as a patient who underwent the treatment. We see a 50% responder rate by this definition of success. If we add on either that pain and functional improvement or cessation of opioid use, then we have 7 patients out of the 10 that we would count as responders. So depending on how you slice it. But again, I think for an axial back pain, chronic back pain population, I think these are looks pretty good. And we haven't yet seen any major complications. I've had one patient who had sort of a temporary radiculitis that persisted for about 10 days and then self-resolved after the procedure, and that's it. So from our experience and from the clinical trial data, it seems like it's a safe procedure if done appropriately. And then, on the horizon, so we are mining the clinical trial data from those 2 large RCTs and looking to do predictive modeling. So how can we better select patients? What are the factors on imaging, on history, on exam, on pain diagrams that might lead us to guess that a patient would be an appropriate candidate or a good candidate for this particular treatment. And then what's going to follow is we are going to be the initial site for and primary investigator for the global registry, which will include mostly US sites, but also some in Europe and Canada. And then eventually what we'd like to do, we're we've kind of been discussing is probably doing our own multi-center pragmatic randomized control trial that is completely arm's length from industry, which would be wonderful and is going to be challenging because of just the cost, of course. But that's really what's coming down the pike. With that, I'll turn the microphone over to Dr. Conger, who I believe is going to speak on knee and shoulder joint denervation, which really is quite distinct from spinal, and he'll talk more about that.
Aaron, you're on mute still.
There we go. Great. Thank you, Dr. McCormick, and everyone for having us here. Excited to talk to you guys about this. I'm going to run through kind of anatomy technique, mostly current evidence, and I think I'm going to have to move kind of quickly here. I think a lot of the value, I don't have any disclosures of this, is going to be the discussion. So Dr. Joyce mentioned that there's minimal surgical literature from Dellen on surgical denervation for different joints. There's basically a case series, as far as I could tell, in that regard. Percutaneous treatments, phenolneurolysis, cryoneurolysis, a few case series, 2 randomized controlled trials for cryoneurolysis now. So the majority of the data comes from radiofrequency ablation, which seems to be mostly the focus that we're discussing today. I wanted to give an update to the group on any clinical practice guidelines that might cover this type of thing. So as of a few days ago, I reviewed these. I didn't find anything for AOS, EULAR, NICE guidelines, really nothing for knee and shoulder OA at least. Some of the newer guidelines that have been published recently from the American College of Rheumatology in 2019 actually do consider radiofrequency and cryoneurolysis sort of within the same group. And they gave a conditional recommendation for the treatment with the caveat that they reviewed only 5 studies. And they felt that the data was limited due to heterogeneous techniques and lack of long-term safety data, which is a fair appraisal of the literature, in my opinion, as well. Since that time, even since that publication was released, which I think reached back into 2016, you can see the number of studies that have been published for ablation for knee has exponentially increased. So even since 2017, I think there was 11 studies that were published just in 2017 alone. And this cuts off about mid-2018. This is from a systematic review that was published in 2020. So there's this long lag time. With so many new studies being published, it just hasn't been included one way or the other, either for or against in many clinical practice guidelines. So I'll try to highlight kind of with broad brushes what the overall literature looks like here. This was a nice review that was published here in Pain Medicine not long ago. It included essentially about 1,500 patients within the multiple studies, 13 randomized controlled trials, a number of kind of case series. And if you look at sort of the different categories of outcomes that were discussed in that review, in terms of the 50% threshold for responder, around 65% of people in the RFA groups compared to around 1 in 5 in the control groups reported at least 50% pain relief. Most of the data is at 3 and 6 months. There's some studies that go out to 12 months, and only one that I'm aware of that followed patients for 24 months. Function was generally improved. And it was measured differently in the different studies, of course, but most of those studies, the majority showed increased function. Satisfaction was high overall. Around 80% of people were satisfied with the results of the procedures, slightly lower with the control groups, of which there were various different controls. Safety is one of the things that really has been reported in the trials and in these small case series, but there isn't a study that includes thousands of people where this has been done to capture more rare side effects. But in the majority of the published studies, up to 29 out of the 33 that were reviewed in this recent systematic review, there was really minor adverse effects. This was a JAOS meta-analysis that was recently published that some of you may be aware of. I read this paper and I've done 2 other reviews on the subject. So I know all of these studies. I think they did a really good job just with their methods and how they kind of went through this. You can see the on the left side here, left column of the right figure, that the 3 months and 6 months responder rates for VAS and NRS really do favor consistently RFA over comparators. The comparators are very broad sham, continued standard of care, oral analgesics, intra-articular injections have been a couple of the major ones. And similar here for function, again, sort of favoring RFA over comparators. If you look at it, just a couple of the key trials here, and these are worth digging into a little bit deeper, but these are essentially industry-funded studies, open label, cooled radiofrequency ablation against either steroid or intra-articular hyaluronic acid. And these are patients that are, chosen for those types of studies. They're cherry-picked. They're not obese. They don't use opioids. They're not depressed. There's no neuropathic pain. And the responder rate in those studies is fairly high, 75% for the 50% threshold pain reduction at 6 months, compared to around 16% for steroid from the Davis study that was published here a couple years ago. This is a tornado plot showing so the kind of the upper right-hand quadrant is showing the number of responders for the 50% threshold for RFA versus steroid on the right. And when we look at a similar study also funded by industry here for the RF versus intra-articular hyaluronic acid, again, a high responder rate at 6 months for the RF group compared to a modest responder rate for intra-articular hyaluronic acid. And you can see that depicted here graphically. The red bar represents the control, the intra-articular HA group, compared to the lower pain scores there for RF. And the 6 month threshold is when they crossed over. They allowed crossover basically at that point. Essentially all participants crossed over, I think, except for maybe 5 or 6 or 10 maybe. So the mass majority crossed over at that point. Similar type of pattern here for functional improvement. And I'm going to speed up just a little bit here. I want to make sure that we save time. This is a recently published retrospective review of about 265 patients. Notably, 50% of the people in this cohort had a total knee arthroplasty, and they reported fairly good outcomes for post TKA ablation, which is unusual compared to some of the older studies. This particular study did target more nerves than the prior studies have. And they found in their kind of regression analysis that multiple lesions at each neural target was strongly associated with treatment success compared to single lesions, which is every study I just showed you is essentially a single lesion performed at 3 nerves: the superior medial site, the superior lateral site, and the inferior medial site to target those genicular nerves. That's essentially every study. So some of the newer studies are being based on the anatomic work by John Tran. These are the original sites, these black dots, essentially, with the exception of that center one. And there are some proposed targets to more thoroughly or more consistently capture these nerves. We published a study on this a couple years ago, creating essentially multiple lesions at these targets to try to capture these additional terminal articular branches. And the more time, I must have revised this figure multiple times in the last 2 years to talk about this, but additional lesions to target these areas. We're involved in the SCOPE trial here, which I won't mention too much just for the point of time, but the key point is if you see that in the lower right-hand corner, that's an N of 800 for phase 1. In a much slightly smaller phase 2 trial, this will be 300 people per group. So by far, in a way, the largest trial for this treatment. And on the right hand, the figure here is showing a much more comprehensive denervation procedure for the anterior capsule. Cryoneurolysis has to be mentioned here, even though it's histologically maybe not the same as radiofrequency ablation. There's been one randomized controlled trial here performed in 2017 that showed treatment benefit. You can see kind of the blue bars here versus the orange bars, which was the sham group, sort of showing improvement at 30, 60, and 90 days at differing points for function and pain. There's another trial protocol just published. This will be coming out here, I'm sure, in another year or two. So for shoulder, there's a lot less data. There's maybe a little bit more to talk about for the anatomy, but really just case series. This is a list of some of the prior anatomic studies. John Tran, again, did one of these really nice meticulous dissections showing that the terminal branches, the suprascapular nerve, axillary nerve, and lateral pectoral nerve kind of innervating different quadrants of the glenohumeral joint, and some going to the acromioclavicular joint. There's a frequency map, again, by John Tran, showing each of those colors represents a single nerve that was seen in a cadaver. So this is, I think, 15 shoulders kind of superimposed on a figure, kind of a CT reconstruction, and showing the various quadrants of the glenohumeral joint being supplied by these different nerves. So based upon that and other cadaveric studies by Ekman, sort of these safe zones of ablation have been developed to target the terminal articular branches while sparing the motor branches. And these are sort of the proposed targets for that, posteriorly and anteriorly, to capture the suprascapular terminal branches, the axillary nerve, and the lateral pectoral nerve. I think notably the lateral pectoral nerve in the vast majority of cadavers really just went to the acromioclavicular joint. There wasn't many that headed towards the glenohumeral joint. This is the single case series for this, so there's not a whole lot of evidence. 34 patients, most of them had glenohumeral OA. They were all selected for the most part with some kind of a diagnostic block. Most of them went on to get RF, and about 50% responder rate. A little bit higher for those having cooled radiofrequency versus thermal, which was discussed earlier by Dr. Joyce. One of the patients had a pacemaker and went into atrial bigeminy that apparently resolved on its own. There's been 2 prior studies, and this is a thermal ablation of the proximal suprascapular nerve, so including the motor fibers. In patients, it was essentially a salvage kind of palliative procedure, massive rotator cuff tears or inoperable glenohumeral OA, and showing various responder rates. I'm going to skip through this. So I think that, the big picture here is that, this is what we're trying to do, is interrupt that sensory afferent, but it's a small part of the overall pain experience for people. There's a lot of other stuff that goes into this. I think, these procedures are very interesting. They still need, at least for shoulders, certainly needs a lot more data. And even for knee, we need longer term outcomes. The newer targeting protocols might be substantially more effective than the older. We don't really know that. Safety data is, it appears safe based on trials, but we don't have 20,000 patients or something to look for these rare side effects. So I'm going to pass the mic here. I want to make sure I save as much time as possible here for Nick.
Thanks, Aaron. I'll present on denervation and hand surgery here briefly. I'm going to get the screen up. All right, so just a quick overview. No conflicts of interest that are pertinent here. We'll go over the wrist, for which the majority of the evidence, which albeit is limited, exists. There's some for the thumb CMC, as well as the finger and metacarpal phalangeal joints. Hopefully we'll have a few minutes for discussion. So here's kind of a classic case where we run into this scenario. Relatively young guy, he's got good range of motion. He's got stage 2 scapholunate advanced collapse, wrist arthritis. Traditional treatment options that we usually entertain would be things like a proximal row carpectomy or 4-corner arthrodesis. These are reliable in reducing pain, improving function, and maintaining the majority of existing motion. And these are kind of the mainstays for treatment of this type of condition. In other cases, if the motion's poor, we sometimes do a total wrist fusion. And there's a variety of other less commonly used, albeit bony and joint procedures that have traditionally been done. The downside to these is the minimum time for patients to proceed to weight bearing is tolerated is somewhere along the lines of 6 weeks, maybe 6 to 8 weeks. So that's a bit of time. It can be dragged out a bit longer as well in some cases. These procedures, the 4-corner fusion and the PRC, they're not perfect operations either. When you get a good result, it's a good result, but somewhere around 6 to 17% of the 4-corner fusions get converted to a total wrist fusion. It's a little lower for PRC. Infection rate is low, but not 0%. And for 4-corner fusion, there's a good chunk of patients getting unplanned operations for hardware removal or treatment of non-unions. So what about denervation? Heard a lot about this this morning. And basically pertinent to the wrist, we've got kind of 4 main players: the posterior and anterior interosseous nerves across the radiocarpal joint. And then you have the dorsal sensory branch of the ulnar nerve and the superficial branch of the radial nerve, are the main ones that are pertinent here. At this level, the AIN and PIN do not provide any motor, or the little branches of the sensory nerves that you're whacking out don't cause cutaneous numbness typically as you're targeting the branches to the joint. Wrist denervation, or neurectomy of the wrist. We've heard some of the history of this. This was first described for the wrist in 1959 for scaphoid non-union. Since then, these wrist denervations have been described as either complete which might be a misnomer. There's no way to actually completely denervate the wrist entirely, complete or total denervation, versus a partial denervation, which is what we do here traditionally, sacrificing the AIN and PIN for central/dorsal wrist pain is what we do here. Since the initial description of the complete denervation, good results have been reported with partial denervation or AIN neurectomy alone. The advantage of wrist denervation for the patient is that it's maybe 2 weeks for a skin incision to heal, and then they're good to go. We tend to do this, the AIN and PIN neurectomy, through this window number 2 that you see here, through an incision that looks like this. And we take out a 2 centimeter segment of the PIN there, dotted in purple, and the AIN as well. In PubMed, for example, this has become a more popular topic, albeit the top of the curve is only 9 publications per year. It's definitely receiving more attention lately, which is good because our evidence is limited so far. I'll briefly go over some reviews, systematic reviews of the current literature. Again, it's limited to kind of level 4 case series, basically. So this was in the European Hand Journal recently, 12 studies. The diagnoses were heterogeneous, which limits our ability to interpret this, some with arthritis, some with Kienbach's disease, some patients with other diagnoses entirely. But 94% returned to work. Pain scores improved anywhere by 36 to 92%. 92% were satisfied with how they defined it. Again, heterogeneous definitions here, and grip strength increased moderately to notably. Here's another systematic review of 292 wrists. This is in the setting of a partial denervation. Reoperation rate was about 24% at 18 months, in which the patients failed in terms of pain relief, and they went on to get more traditional salvage procedures in that time frame. Here's another systematic review that tried to compare a complete wrist denervation versus a partial wrist denervation. They identified and studied 21 basically case series. They noted that the quality of evidence was poor, and reoperation rates were significantly different, but hard to interpret given the heterogeneity of the studies. 19% for the partial denervation group and 5% for the complete group. Moving on here, we've basically got a single series out of Mayo Clinic. This is one that we commonly cite as hand surgeons. They studied 100 wrists. Mean follow-up was nearly 7 years with a minimum of 1 year. And about 70% of patients were free of undergoing their salvage procedure at almost 7 years after the AIN and PIN neurectomy, again, a partial denervation here. The mean reoperation was at 26 months for those who had to undergo a traditional salvage procedure. Mayo risk scores improved in terms of significance and clinical relevance. It's a good magnitude of improvement, and grip strength was pretty close to the contralateral side. So overall, pretty promising results, at least from this one center with their technique. This is a recent study as well that evaluated the influence of basically wrist denervation, AIN and or PIN neurectomy in the setting of doing a salvage procedure like a PRC or four-corner fusion. This was in the setting of post-traumatic wrist arthritis. They basically found that doing the wrist denervation at the time of the salvage procedure was protective against undergoing a total wrist fusion with odds ratios of around 0.2% or lower, which is pretty impressive. I interpret this as it's reasonable to perform those probably at the same time as doing a wrist salvage procedure, because they're kind of there anyway, and it might be beneficial. Another study, this is very limited. We heard a lot about RFA. There's not a lot of evidence in the wrist. This was the main thing I found is 2 patients, one it worked, one it didn't work. So there's some room for study there for sure. Is there an effect on wrist proprioception? Are we causing people to have Charcot wrists? In essence, no. This study looked at proprioception, and at a mean of 32 months postoperatively after AIN and PIN neurectomy, proprioception was the same as for untreated control patients. Another thing that Andy wanted me to get into a little bit was just kind of financial incentivization here. So these are work relative value units for a PRC, which takes about an hour. With our U of U data, it's about 8 RVUs. Four-cornered fusion with bone graft, it's less than 10. It takes about 2 hours to do. Doing a single nerve neurectomy, it takes literally like 5 minutes to do, and it's like 8. So something to think about there. The other thing too is folks who are not traditional hand surgeons, say neurosurgery or plastics without a hand focus or something else entirely, could potentially do a neurectomy without, maybe discussing some of these other salvage procedures. So here's one description of all of the nerves innervating the wrist. There's like 14. No one can agree on how much you have to do and how much is enough. Again, some reports that an AIN neurectomy alone is sufficient. Some reports of AIN and PIN being sufficient. There's others who do a lot more. So we need a little bit more information guiding us on how much we have to do to get a reasonable result. Moving on to thumb CMC, I'll try to be brief because the evidence is very sparse. Basically, anything that we do for thumb arthritis has a high bar to meet. Ligament reconstruction, tendon interposition is the mainstay for this. It's been reliable. High rates of patient satisfaction and improvement, meaningful improvement in patient-reported outcomes at 3 months are noted pretty much universally, although it's a couple months of non-weight bearing and can take a little bit longer for a full recovery is the main downside. So there's very little on thumb CMC denervation. Systematic review had 184 procedures, mean follow-up around 3 years, maybe 10 out of 184 underwent LRTI, and then about 11% had pretty trivial minor complications. Again, these are very small case series of patients that have, this is kind of their thing. They want to publish on this. Thankfully, we're hopefully in 2022, we'll have results from this, which is a randomized trial of LRTI versus thumb CMC denervation. This will be a high-level study, hopefully, that will give us some really good information, which is currently lacking. Hand and finger, there's even less yet. I won't belabor it, but the single systematic review I could find had 12 studies. Sample sizes were low for the distal interphalangeal joint. 2 articles with 15 patients looked like a pretty high rate of complications there was noted. For the proximal interphalangeal joint, bumped that up to 3 articles and 51 patients. Pain scores got better, but a little over 10% had treatment failure and needed a fusion or arthroplasty or something along those lines. And then for the MCP, 2 articles, 19 patients. So really, these are too small sample sizes to make anything of, and the jury is out on these. So to kind of wrap things up, who should be doing denervation procedures, or should we even be doing them? Is kind of the main question. Probably not necessarily something I can advocate for in the hand or fingers. For the wrist, I think it's a little bit more maybe reliable with a little bit more evidence behind it. Again, we don't have a randomized trial for the wrist either. The other concern is, if you're a hammer, everything's a nail. If all you do is nerve surgery, then you might not offer the full spectrum of treatment options to the patient. And it's really a shared decision-making model that leads to the best, plan for these patients undergoing surgery in terms of what to expect, what the options are. Wrist denervation done in conjunction with the wrist salvage procedure, I think that's kind of a pretty low bar. I do it. I don't think everybody does it, but based on one of the studies showing reduced risk of total wrist fusion, I think it's reasonable to entertain that. Should we do denervation prior to salvage procedures, whether that's in the wrist or a knee replacement or some sort of back surgery? Should we recommend that universally or not? And then who should and shouldn't do these, which I alluded to before, and implications for others, more common sites of arthritis. Should we be doing this or not? But thank you for your time, and hopefully we have a minute or two to chat.
Thanks, Nick. Thanks, Aaron, Andrew, and Zach too. It was very interesting, and I'm hoping this might stimulate a little discussion. Anybody here on the call have any thoughts on this broadly? Do you use it? Especially, I'm interested in hearing from foot and ankle surgeons, knee surgeons, shoulder surgeons. Is this something you've considered, or thoughts on this? Denervation procedures have worked their way into hand surgery, and they're commonly discussed now. And I think that with the other surgical subspecialties within orthopedics, we may see a similar future. Let me ask some of the presenters. Aaron, what do you think? I mean, do you think you presented on hip and shoulder? Do you think, if you're going to predict the future here, is this something that you're going to see more and more patients asking for, more and more patients getting as a first-line treatment prior to total knee, as kind of Nick was suggesting?
Yeah, well, I'll talk about knee. Well, I'll just say for shoulder, I mean, you saw the data for it. It's basically a single case series, right? So I think it's probably 5 to 10 years behind knee in terms of just the literature itself. So I don't think anybody really even knows about shoulder denervation, to be honest, in terms of patients. So I think that that's really way too early to say. And personally, I wouldn't be really willing to offer that outside of a study, in my opinion, just for shoulder. I'm just a little bit more risk averse. In terms of the knee, I mean, I kind of hopefully gave an overview of the number of studies that are exploding for this. So it's certainly, and there's more and more studies that are coming out for this. Now, where it fits in the clinical paradigm, I think I'll echo what Nick said earlier. The way I think of this is really a shared decision-making process, trying to balance the risks, the benefits, and the alternatives. I think that it will with the current literature where it's at right now, I think it's a useful stopgap for people that are not otherwise good arthroplasty candidates. And I think that the other thing is we talk a lot about just pain, but these, at least, in my opinion, for knee, this will reduce pain, but it doesn't improve joint-related function. And there's a whole host of other, biomechanical changes that these people have. And if you take away some of the pain, it doesn't necessarily improve some of the other issues. So I think that in its current state, it's a useful intermediary, but I don't think necessarily has to be offered to patients by any means. It's a case-by-case thing, in my opinion.
This is Pelt. I was waiting for Charlie to ask his question that he wanted to ask, but I didn't hear him ask it. So I was just going to give my perspective. I wrote a chapter for the Academy on non-operative knee management, and I think if we would have written this 5 years ago, this technology wouldn't be a part of the chapter. And with today's evidence, it probably is one of the more both exciting but also evidence-based discussions that we could talk about in the chapter alone. Because if you look at the data, things that we've done for decades, like corticosteroid injections, and we can even discuss hyaluronic acid, and Dr. Burks may have some opinions on that, but the data seems to be stronger in randomized controlled trials for the use of this for the management or conservative management of knee osteoarthritis, for example. And as Aaron mentioned, there's also excitement perhaps about some of the painful total knee, this 15% population that we're still chasing to figure out how we make better and can't when other diagnoses aren't present. Can we make them have less pain? And there's some opportunity that exists there. But I guess my point is the data that has been shown today is actually stronger for this technology than corticosteroid injections, which we all do ad nauseum in patients for any musculoskeletal condition without any thought about it. And the evidence to support that practice is very poor.
Yeah, I would agree, Chris. I don't know the knee literature like you do, obviously, but in hand, it has been, I don't want to say paradigm shifting, but it has definitely been a major change. And there is, as Nick went over, some fairly strong evidence for it, at least as strong as the other evidence we have for most of our surgical treatments. And so I think we need to wrap this up here pretty quickly, but I think that this denervation concept is something that should be on everybody's radar. And to that point, I really appreciate Zach, Nick, Andrew, and Aaron kind of giving us an overview of the technology, where we've been, where we're going, and how it's starting to affect even the surgical literature now within orthopedics. So thank you again. Any final questions before we wrap it up?
I'll just make one final comment. Again, thanks so much for having us. And I'll just say, sort of putting on the research hat, there are a lot of gaps to fill, and even in spine, in the scoliosis, spondylolisthesis, post-spinal fusion, these are populations that just have not really been looked at specifically with denervation. And then, clearly shoulder, as Dr. Conger mentioned, and we can do this, right? Like we have, tremendous resources, and this is an area that, we can develop the literature in this area. Knee, we're doing that, right? I mean, and we have partnership already. We've been, working on knee. Shoulders another area. Frankly, I love hearing your talk, Nick, because really this is not an area that we think much about, denervation with the wrist in hand. It just hasn't made its way into sort of the world of, PM&R, pain, MSK intervention in the non-surgical world. So anyway, I think a lot of good, this is a frontier, and, we should be pushing it forward. So thanks again, everyone.
Thanks, everybody.
Thank you.
Thanks, guys.